Hello, my name is Bukola, and I'm going to present on implementation of a nurse-led evidence-based pressure prevention bundle to reduce the incidence of acquired pressure in med-surg unit or in an hospital. My presentation focuses on preventing hospital-acquired pressure injuries through a standardized evidence-based pressure bundle. Pressure injury are an important patient safety, especially among hospitalized patients who are bedbound or have limited mobility. These patients may be unable to reposition themselves, which increases their risk for tissue damage because pressure injury development is influenced by multiple factors. Prevention should not depend on one intervention alone. Instead, evidence supports using several preventive interventions together as a standardized care bundle. Recent systematic reviews have found that pressure injury prevention bundles can reduce hospital-acquired injury rates. The purpose of this proposed practice is to improve consistency in practices and ultimately reduce hospital-acquired pressure injury. Pressure injury are a significant patient safety problem because they can lead to serious physical and emotional consequences for hospitalized patients. Patients who are bedbound or have limited mobility are particularly vulnerable because prolonged pressure can reduce tissue perfusion and cause tissue damage. Other contributing factors include impaired sensation, moisture, friction and shearing, and inadequate nutrition. The consequences can include pain, infection, delayed recovery, longer hospital stays, reduced quality of life, and an increased healthcare costs. Another important concern is that pressure injury can reflect gaps in preventive care, such as inconsistent repositioning, incomplete skin assessment, or inadequate documentation. Therefore, prevention requires early identification of patients at risk and consistent implementation of evidence-based intervention throughout the patient's hospitalization. The goal is not simply to treat a pressure injury after it develops, but to prevent avoidable injuries from occurring in the first place. My PICOT question provides the framework for this proposed practice change. P stands for population. Population is hospitalized adult patients who are bedbound, have impaired mobility, and at moderate or high risk for pressure injury. I stands for intervention and is a standardized pressure injury prevention bundle. The bundle includes risk assessment using the Braden scale, scheduled repositioning, daily skin assessment, pressure redistributing surfaces, moisture management, nutritional screening and support, staff education, and compliance monitoring. C stands for comparison. Is the routine nursing care without standard prevention bundle. Although routine care may include some of these interventions, implementation can vary because of staffing, workload, knowledge, and documentation challenges. The outcome is a reduction in hospital-acquired pressure injuries. Additional process outcome is compliance with skin assessment, repositioning, documentation, and other bundle components. T stands for time, and the time is 8 to 12 weeks. Therefore, my PICO question is, in hospitalized bedbound adults at moderate to high risk for pressure injury, how does implementation of a standardized evidence-based prevention bundle compare with routine nursing care affect the incidence of hospital-acquired pressure injury over 12 weeks? Care bundles are appropriate for this problem because pressure injury prevention requires multiple interventions working together. Shaboya et al. 2024 found that prevention bundles were associated with lower hospital-acquired pressure injury rates. Summary of search strategy. For my literature search, I focus on evidence related to pressure injury prevention in bedbound and immobile adult patients. I search PubMed, CNL, Cochrane Library, and Google Scholar. My search terms included pressure ulcer, pressure injury prevention, bedbound patient, immobile patient, repositioning, skin assessment, support surfaces, and nursing interventions. I combined these terms using Boolean operators such as and or to make the search more specific. My inclusion criteria were peer-reviewed studies involving adults published within the past 5 years and focused on pressure injury prevention. I prioritized systematic reviews, meta-analysis, randomized control trial, and other design studies. I excluded pediatric studies, opinion articles, case studies, non-peer-reviewed publications, and studies focused primarily on treatment rather than prevention. The search produced more than 8 relevant studies. I selected the strongest and most relevant evidence based on study design, sample size, publication date, relevance to my PICOT question, and consistency of findings. 3 important recent sources were Shaboya et al. 2024, Deming and Karagat 2025, McMahon et al. 2026. The literature supports the use of standardized multi-component prevention strategies. First, Shaboya et al. 2024 conducted a systematic review and meta-analysis of pressure injury prevention bundles. 9 studies were included. The pool risk ratio for hospital-acquired prevention pressure injury rate was 0.31, suggesting a substantial reduction associated with bundle implementation. However, the authors also reported that the certainty of evidence was very low, so the results should be interpreted cautiously. Second, the Me and Karadag 2025 conducted a systematic review and meta-analysis that included 9 studies and approximately 29,000 patients. Their findings showed that care bundles significantly reduced hospital-acquired pressure injury rates, the number and severity of pressure injuries, and the length of hospital stay. The third publication, McMahon et al. 2026, examined organizational strategies for pressure injury prevention in acute care hospitals. 7 prevention studies were included, and 6 reported reductions in pressure injury incidents. Education, audit, and feedback, continuous quality improvement, and other organizational strategies were commonly used. Overall, these findings support my proposed practice change. The evidence suggests that pressure injury is more effective when multiple interventions are implemented together and supported by education, monitoring, and organization strategies. The proposed change will take place in an acute care hospital setting. The primary population will be hospitalized adults who are bedbound or have significant mobility limitations, are at moderate to high risk for pressure injuries. An interdisciplinary team will be involved in the change. This team may include registered nurses, nursing assistants, nurse managers, wound care specialists, dietitians, physical therapists, occupational therapists, and physicians. The patients and families are also important stakeholders because they can participate in prevention activities and communicate concerns related to discomfort, repositioning, nutrition, or skin changes. An interdisciplinary approach is important because pressure injury prevention involves several areas of care, including mobility, nutrition, skin assessment, equipment, and nursing care. How we use Lewin's change theory, which includes 3 stages. The first stage is unfreezing, changing, and refreezing. The first stage. During this stage, staff will be shown baseline pressure injury data and the patient safety impact of pressure injuries. Barriers to current prevention practices will also be identified. The goal of this stage is to create awareness and readiness for change. The second stage is changing. During this stage, the prevention bundle will be introduced. Nurses and nursing assistants will receive education about the bundle. Documentation will be standardized and appropriate support services will be provided. Compliance will be monitored and staff will receive feedback and coaching. The final stage is refreezing. The successful practices will be incorporated into routine workflow and organizational policies. Staff education and compliance monitoring will continue, and outcome data will be shared with the team. Lewis' model is appropriate because this practice change requires changes in staff behavior, workflow, communication, and accountability. The primary evaluation criterion will be whether the intervention decreases the incidence of hospital-acquired pressure injuries during the 12 implementation period. The primary outcome measure will be the hospital-acquired pressure injury rate. Process measures will determine whether the pressure bundle was actually implemented as planned. These measures will include the percentage of eligible patients receiving documented skin assessment, the percentage of scheduled repositioning interventions completed, appropriate use of pressure redistributing surfaces, completion of nutritional assessment, moisture management intervention, and staff completion of education. I will use a proposed target of at least 90% bundle adherence, although this target can be adjusted according to organizational quality improvement standards. Balancing measures will also be monitored. This will include unintended consequences such as increased staff workload, documentation burden, patient discomfort, or delay in other patient care activities. This evaluation approach will allow me to determine both whether the intervention worked and whether it was implemented as intended. Data collection. Data will be collected before and during implementation to establish baseline performance and evaluate changes after the prevention bundle is introduced. Data sources will include electronic health records, standardized skin assessment forms, nursing documentation, repositioning documentation, quality improvement reports, and staff education records. The main outcome measures will be pressure injury incidence and prevalence. Incidence refers to new pressure injuries that develop during the measurement period. Prevalence refers to the proportion of patients who have a pressure injury at a specific point or period. Descriptive statistics will be used to summarize these data. I will also use run charts to display weekly or monthly pressure injury rates and identify trends over time. The data will be reviewed regularly during implementation. This will allow the team to identify barriers quickly and make adjustments rather than waiting until the end of the project. Plan for dissemination. Dissemination is important because the result needs to reach the people who can use the findings to improve patient care. The results will first be shared with unit staff because nurses and nursing assistants will be directly involved in implementing the prevention bundle. Findings will also be presented to nursing leadership the Nursing Council, the Quality Improvement Committee, and the Patient Safety Committee. Results can also be displayed on the organization's quality dashboard to provide ongoing feedback. If the project produces meaningful findings, the result may also be presented at a nursing or evidence-based practice conference. Importantly, I will report both successful and unsuccessful findings. I will also describe barriers, challenges, and lessons learned. Sharing both positive and negative findings can help the organization determine what should be continued, modified, or improved. In conclusion, pressure injuries are a significant patient safety concern, particularly among hospitalized patients who are bedbound or have limited mobility. Prevention requires a consistent and comprehensive approach because multiple factors contribute to pressure injury development. Recent evidence supports the use of standardized prevention bundles. Shaboa et al. 2024 found that care bundles were associated with lower hospital-acquired pressure injury rates, although the certainty of evidence was low. The Mill-Carragher 2025 also found significant benefits associated with care bundles, including reduction in pressure injury rate, injury burden, and length of stay. McMahon et al. 2026 further demonstrated the potential value of organizational strategies such as education, audit, and feedback, and quality improvement. The proposed practice change combines this evidence-based strategy into a standardized prevention bundle. Using Lewis chain theory will provide a structured process for preparing staff, implementing the intervention, and sustaining change. Ultimately, the goal is to improve consistency in pressure injury prevention, strengthen staff accountability, and reduce preventable hospital-acquired pressure injury. The reference slides contain the complete APA 7 references used to support this presentation. Thank you.